Good morning, good afternoon, good evening, everyone, depending on where you're connecting from. Welcome to the third and the final webinar part series on inoculation against misinformation. My name is Lucy Kanja. I am an immunization advocate and a Boost community member. I'll be the moderator for today's session. As mentioned briefly, today's webinar is part of a three-part series on vaccine misinformation. It has been co-sponsored by the Sabin Vaccine Institute, the Boost community, and UNICEF. These groups are working together to help the immunization community understand mis and disinformation and develop and employ strategies to manage it in order to improve vaccine acceptance. So as I have mentioned, we had our first webinar in October, which was on misinformation, a strategic approach. So the key takeaways from that webinar were misinformation is tricky. So we are likely to believe in things that we have heard many times, more than the new information. So misinformation most of the time is presented in an emotional language that is persuasive and attention grabbing. And then another finding was that people often continue to rely on misinformation in their reasoning even after it has been corrected. So in terms of approaches, so social listening allows us to listen through the fog of disinformation. Social listening also allows us to hear the concerns of the people about vaccines and misinformation. And then social listening as well allows us to respond through trusted voices. I am underscoring the word trusted voices that are going to reassure them, to make them feel heard, because it's important for them to make them feel heard. In addition, social data analytics and social listening. So this is basically the tracking, the monitoring and use of data that comes out from the social media platforms to inform programs, influence decisions, and also that can also make us understand the stickiness of the information, since erroneous social media messages should not go unchecked. And we need to actively and systematically monitor and address misinformation. So in addition, in November, we had another webinar. Next slide, please. So the takeaways from the webinar, the webinar was on infodemiology in practice. So the takeaways from the webinar are misinformation flourishes in the absence of quality information. So basically, we need to flood the zone and strategically improve health communication through emotional storytelling. As we've seen, misinformation does the same, uses emotions and all that. So we need to do the same, but with factual information. So we also need to understand the psychological reasons why people are vulnerable to information. So this calls for collaboration beyond the immunization space. So collaboration with the social and behavioral sciences to learn about this. So to combat misinformation, we need to consider the ABCs of misinformation, that is actors, so behaviors and content. We need to understand the manipulative actors that come to the information ecosystem. We need to understand the tactics that they use, maybe deceptive behaviors. And also we need to understand the content that they're releasing. Is it harmful for us to address it? So community involvement is key in this, in fighting against misinformation. So we need to build our community and debunk information, then hold each other accountable and educate networks. So also compassion and empathy are important when responding to the spread of misinformation. It is important to ask people where they get their information from and why they believe it. Encourage them also to think critically about the sources of this information. Next slide. So welcome to today's webinar. The instructions are: kindly mute yourself to limit background noise and feedback. Use the raise hand function during discussion to speak. And then kindly submit your questions in the Q&A. Use the Q&A and not the chat for the question. And then you can introduce yourself using the chat function. Next slide. So we have 3 panelists today. Our agenda today, we have 3 panelists. We have Dr. Stephan Lewandowsky. We also have Bright Simmons and Lucy Kanja. So we'll have those presentations. And then in between, after the first presentation, we'll allow 1 to 2 questions. And then we'll go over to the next presenter. Then allow 1 to 2 questions. Then we'll have the final presentation. And after that, we'll open it up for the questions. Then wrap it up. So allow me to introduce the presenters for today, the panelists. So we have Lucy Kanja. She's a coordinator for the expanded program on immunization in Lang'ata and Kibera sub-county in Kenya. And we have Dr. Stephan Lewandowsky, who's a cognitive scientist at the University of Bristol and also an author of the Debunking Handbook. Last but not least, we have Bright Simmons, who's the founder and president of mPedigree. So we'll start with our first presentation of the day. So I'm going to invite Dr. Stephan Lewandowsky to present on inoculation versus anti-vaccination misinformation. Stephan, you're welcome.
Thank you. So I hope you can see my screen. Yes, I just want to talk about inoculation specifically, and to place this into context, I want to remind you that, well, you probably don't need a reminder, that we're operating in very challenging times where a lot of leading politicians are issuing lots of falsehoods. Now, Donald Trump is relevant and responsible for a lot of things, but what I find most striking is that a recent study has identified him as being the leading source of COVID misinformation globally. And this was done based on an analysis of millions and millions of documents from around the globe. So if you're working in the public health arena, then misinformation is a serious problem. And as I know you know from the earlier webinar, misinformation sticks. It sticks in memory because once people hear or see a message, they tend to, first of all, believe it. And secondly, they tend to remember it, at least a little bit. Now, when that message, the initial message is corrected, as in this example concerning Donald Trump, then the correction may sometimes be partially effective, but even when people say that they know something has been corrected and that the myth they were exposed to is actually false, they may still act as if they rely on it. And one of the reasons for that is that if you're listening to the world around you and you're forming a mental model in your head of an event, then it is very difficult for a key element of that model to be removed without a replacement. Because how are you going to explain the world if half of what you thought was true about it is no longer true? Now, misinformation is a critical issue. We now have quite a bit of data, including in the context of the COVID pandemic, that misinformation is causally responsible for determining people's behavior. Here are two recent studies published this year that looked at the causal effects of watching particular TV shows in the United States and how that affected their social distancing, and in an extreme case, even the number of people who die from COVID. So misinformation matters in a lot of contexts. This is just the most recent snapshot about the specific effects within COVID. Now, that doesn't mean we're helpless or that the situation is hopeless. There are things we can do. One of them is proper debunking, which you can read about in the Debunking Handbook. The other thing is inoculation, which is what I want to talk about today. Now, inoculation in the context of misinformation has two elements. First, you warn people that they may be misled. Secondly, you refute an anticipated argument by exposing the fallacy in that argument. Now, the good thing about that is, the good thing about this working is that you don't have to know ahead of time what exactly it is people will be misinformed with. All you have to know ahead of time is how they might be misinformed. And that turns out to be reasonably easy to know because professional misinformers are using a toolbox over and over again that we can analyze and we can then use to inoculate people against being misled. So I just want to go through two examples of inoculation. The first one is a published study by my colleague Karen Douglas from a few years ago, which relates specifically to vaccinations. And what I'm showing you here are data from three conditions in that experiment: a control condition in which people weren't exposed to anything, a conspiracy condition in which people were exposed to a conspiracy theory about vaccinations, the usual thing about the pharmaceutical industry and some other villains. And as you can see, what that did was to significantly reduce the intention to vaccinate. And more concerningly, what you can also see that if you follow the conspiracy with a counter message afterwards, it doesn't undo the effect of the conspiracy, at least not completely. And that, of course, is problematic because what do you do if you can't correct a conspiracy theory? Well, turns out in this study, there was another condition in which people were also exposed to a conspiracy. However, that happened after they were told that they might be misinformed through a conspiracy theory. And when that happens, then the adverse effects of the conspiracy theory are removed, or at least attenuated far more so than they were by a rebuttal afterwards. So that's one study. Here's another study I want to walk you through that is from a series of experiments currently in progress with these co-authors, where what we do is we show people brief videos about how they might be misled, including using techniques that are used by anti-vax disinformation. And afterwards, we measure how much people are affected by that misleading information. And these are large studies with, 1,000 or more American residents. We separate them into two groups, one an experimental group, then a control group. We then test their ability afterwards to tell between neutral and misleading social media posts. And the crucial manipulation or intervention is the video that we show people in the inoculation group. And just for fun, I'm going to play the video that we're using in one of the experiments. I'll play that to you to give you an idea of how this works.
You might think about skipping this ad. Don't. What happens next will make you tear up. Wait, you're still here? I mean, great. Looks like the trick worked. You see, when watching videos or browsing online, you're likely to encounter content that is loaded with emotional language, and with good reason. Playing into emotions, especially negative ones such as fear, anger, or contempt, is a trick to get you to pay attention to something when you otherwise wouldn't. It's likely that is a big part of the reason you're still watching this ad is because you were lured in by our use of emotional language in the very first sentence. Research has shown that expressing emotion is key for the spread of moral and especially political ideas in social networks. So let's say when you're writing a headline and you're trying your hardest to manipulate your readers to click. One thing you can do is pepper your headlines with a bunch of emotionally charged words. Call it a horrific accident instead of a serious one, a disgusting ruling instead of a disagreeable one, or a heartbreaking twist of fate instead of an unfortunate coincidence. That way, you're likely to reach more people and influence their reactions. So let's see how this plays out in real life. Let's take the following headline from the movie Anchorman. No emotional manipulation at play here, just to the point, no nonsense coverage of such an important event in world history. This headline, on the other hand, see what they did there? The writer used an emotionally charged word like revolting to describe a whole group of people. I mean, it's people. Oh well, you get the point. They're fear-mongering. So whenever you feel outraged or angry, remember, someone may be pulling your strings. Don't be manipulated. Truth Labs, the whole truth and nothing but the truth.
Okay, so that's the kind of brief, vaguely entertaining video that people watch. That is then followed by test items, such as the one shown here, that either is or is not emotionally manipulative. You can guess which one that is. It starts out with, beware, an 8-year-old girl was abducted yesterday at Disney World. It's all very exciting. And people then have to indicate whether they find this to be manipulative, whether they're confident in their assessment, and whether they want to share this post and how trustworthy it is. So that's the type of experiment we do. If you look at the data, looking at the discernment, that is the different scores, then we see a fairly strong effect, at least when it comes to manipulativeness. I'm highlighting the difference between the conditions using the red line, between the control on the left, the inoculation on the right. And you can see that people become better at differentiating manipulative from non-manipulative content by a fair amount. The same pattern arises for judgments of trustworthiness, for sharing intention. The sharing intention effect is small. However, if you rolled out this intervention on social media and you extrapolate to how many fewer people would share manipulative content, then I think this would scale up very nicely. So to sum this up, what's the current state of inoculation research? Well, there's been numerous demonstrations now of inoculation against misinformation. I have a study in the pipeline that applied it to radicalizing material, Islamophobic and Islamist extremism. We were able to guard against that. I've just shown you how it can successfully inoculate people against emotional manipulation. It can be used against conspiracy theories relating to vaccinations and other disinformation techniques that are common among people who are undermining public trust in vaccinations. So if this is something you can do, if you have the technical facilities to do this, then there seems to be a lot of evidence and support. And if you want to go beyond that and you want to know a bit more about how best to rebut information once it's out there, then feel free to download the new Debunking Handbook that has been authored by more than 20 global experts in the field. And I'll leave it at that. Thank you very much.
Thank you so much, Dr. Stephen. So I'm going to let one participant ask a question. So go ahead and unmute yourself and ask your question. Probably raise your hand up so that I can call out your name. And okay, Christine, go ahead, unmute yourself and kindly ask your question. Then Susan will take a question from Susan as well. So we'll start with Christine.
Hello, everyone. I'm Christine from Geneva. Apologies if this question's already been covered. But I was just wondering what might be some of the reasons that people spread misinformation. Thank you.
Right. Okay. Well, very good question. I think the answer covers a lot of ground. There are some people who do it by accident because they think it's true. There are other people who do it because the misinformation is appealing to them, either because it is funny or emotional or it fits within their political views. Then there are people who do it to upset others. I think I sometimes get the sense there is some intent behind that to get other people all excited or outraged. And finally, there's a unfortunately large number of people who do it professionally in order to spread misinformation. And especially with vaccinations, there is some evidence to suggest that trolls, automated accounts on Twitter, are responsible for a notable share of misinformation about vaccinations. Now, there are different estimates of that, and I don't want to commit myself to a particular number, but they're certainly out there, and they're certainly trying to undermine public confidence. So it's a large mix of factors and people who do that.
Thank you. So maybe I can ask this question.
Yes.
There's a question
Okay.
for you. Okay,
Thank
go
you.
ahead. Go ahead, please, Susan.
Thanks very much for an interesting presentation. It's Sue Goldstein from South Africa. I'm just wondering if you've done any of this on a general population, not on in an experimental setting.
Well, the people in this particular experiment I just talked about were representative Americans. I mean, they were in an experiment, but online. So we were simulating the kind of situation people might encounter online. They were sampled representatively. So they're all genders, ages, ethnicities, areas in the US. It was all in there. So now you can always argue that people in an experiment adjust their behavior somehow. But other than that, these were real people that you would randomly encounter on the streets of America.
Sorry, one more question. How did you select them?
Oh, well, we used a panel provider. We used, I think, Prolific for this one. They have panels of tens of thousands of people who are available for experimentation, and they're invited to participate. And the invitations are issued in proportion to the number of people of a certain ethnicity and gender in the population. So, and in the end, then, in the 1,000 people, we end up with something that looks a lot like the American population. It's not perfect, but it's pretty close.
Thank you so much. So I'm going to invite Angus to ask his question live.
Thank you, Lucy. Steve, thanks very much. That was great. And I'd like to bounce off the first question that you got about people's motivations. So you've written also that we can potentially inoculate people not just through highlighting the tactics that are being used to pull the wool over their eyes, but also those underlying motivations. And maybe for misinformation, as you noted, there are many motivations, but for disinformation, when you look at vaccination disinformation, there are probably three, and the biggest one is monetized, but we see politicization and the use of bots, for example, to polarize society from state actors. My question is, do you think that this is another angle that we could take with vaccination against vaccine misinformation, highlighting those kind of malicious intents of the disinformation actors? Over.
Yes, I think, yes, I think, you certainly are entitled, or I think it's ethically appropriate to inform the population that, hey, there are people out there whose goal it is to misinform you and who are doing it for monetary reasons, political reasons, whatever it is, and they're not being truthful with you. I in fact think that is an essential thing to do, that you have to identify those people out there. I mean, maybe not by name, that's when it gets to be kind of tricky, but certainly give the public the tools to interrogate a source so they know what's going on here, and I actually have a series of experiments sort of in the pipeline somewhere. There's so many things I don't get around to writing them all out. Where we successfully train people to identify bots on Twitter in a 5-minute video, and once they learn to do that, they can then identify misinformation, or at least they can say, hey, this guy, no, I don't really trust him. So it is possible to do that. It is possible to get people to become more digitally literate. Absolutely.
That's great. And to the second point, the second question that you got from Susan Goldstein, I just wonder whether we now need to be really ambitious. I mean, we're public health people. Your videos are really interesting. We've seen games can effectively inoculate large numbers of people pretty quickly. Should we start now thinking about national immunization programs against vaccine misinformation?
Yes. Again, yes, of course we should, especially with COVID-19, because one of the things about the COVID-19 vaccine is that we already know what the contrarian arguments are going to be against it, and one of them will be the speed of development. People will say, oh, that's too fast. It's kind of like, really? You wanted to suffer more? I don't quite get that, but never mind that. It's that'll be held against it. And so we got to anticipate that and maybe inform people how the testing really happened and how, this was sufficient or whatever. And the second thing is that it's somehow an RNA virus, and therefore the RNA vaccine is somehow different. I'm not an expert in vaccination, so I can't speak to the veracity of that. I just hear what the contrarians are saying, and their talking points will settle, I think, on at least those two different things. So absolutely, we should anticipate that. But I think what's perhaps even more important is, rather than anticipating just the contrarianism, is to point out that most people around the world are actually dying to take this thing. I got data from a recent survey in Finland where I think it was up to 3/4 of the public wanted this thing. In the UK, it's 60-something%. And those are actually quite high numbers, given that it's not even available yet, and it's all very hypothetical. I see those numbers go up. I also think that if it is rolled out properly and is made available easily and cheaply or free, then that's far more important than dealing with anti-vaxxers, I think. If people can do it, they'll do it. And there's so many other things we can do, like underscore the scientific consensus and emphasize how this is your ticket to freedom. And I mean, there's so many positive messages you can associate with that vaccine that I think a properly done information campaign will get us to a point where uptake is sufficient to really cut this pandemic, just decapitate it, I hope. And I'm pretty confident we can do it.
Thank you so much for the questions, attendees, and also responding to the question, Dr. Stephan. So we'll move on to the next presenter, but then keep your questions coming. We'll have a chance at the end of the presentation to answer the questions. So we'll move on to Bright Simmons, the next presenter, who's a founder and president of mPedigree. He's going to present on the importance of developing solutions for managing misinformation from within communities, including successful examples and how to determine success. So I'll invite Bright to share his screen and go ahead and present.
Thank you very much, Lucy. So I'm going to turn on my video, but if I sense that the bandwidth is not holding up, I might just turn it off again, and I hope no one will take offense. I'm now operating out of the outskirts of Accra, so the internet is not as strong as it should be. I'm grateful for the opportunity to present. What I'm going to do is share my screen in a minute, if you allow me. Okay, thank you. So I'm here to present on inoculation against misinformation, as everybody knows, focusing on some solutions that might be viable, and using obviously my experience as a technologist, but primarily a social technologist. First, I'll try and be a bit theoretical, just because I need to validate the roots analysis that has led to some of these suggestions that I'm going to make on this panel. And I think part of that is, first of all, diagnosing what we're up against. So if we say people are chronically susceptible to misinformation, and obviously people are not susceptible to misinformation, then we don't have to inoculate them against misinformation. It's almost like the medical analogy. Somebody has to be susceptible to infection for you to bother vaccinating them. If people are naturally immune by some measure, then we don't have to inoculate them. So I think the starting point is to figure out what is it that makes some people susceptible to misinformation, and then maybe look at a few models. And then I'll end with a range of ideas that link to solution seeking in this respect. One of the fascinating areas that has come to the attention of people that are in this space of quality information dissemination is that for a lot of people, the reason why they prefer what some of us call conspiracies or misinformation or disinformation, and I'm not going to get into the value judgment around who has the right to call something misinformation or the rest, because we don't leave this webinar if we started on that trajectory. So I'm just going to assume that we are all kind of familiar with what is misinformation and what is not misinformation. I'm also going to assume that our society is sufficiently sophisticated to have a mainstream that kind of align with the right information or the truth, so to speak. So if you live in a society where fundamentally the mainstream is not, then we get into a really perverse philosophical discussion I'm not going to go into. So the assumption is that you have a society where the mainstream supports the truth or the right information, and therefore misinformation is some kind of minority phenomenon. And why will people become susceptible to misinformation? They will become susceptible to information regardless of how educated they are, regardless of how well-intentioned they are. If there's a sense that there's a higher truth to which this misinformation is aiming for, that there is something hidden from the traditional or the conventional view, that until you look at things this way, you reorganize your thought processes, you can't reach this higher truth. In street politics, in online street politics, if you're the kind of person who spends time on Twitter or any of these online media, the term that is often used is wokeness, and that can be for positive or derogatory sense, in a positive or derogatory sense. And now I'm using it in the derogatory sense. So wokeness is the sense in which you question everything and argue that there's a higher truth, and what is presented to you as the obvious fact cannot be that obvious. There must be some other thing that goes beyond this obviousness. The second is what I call tribal cognition, and it's based on this notion that we live in an environment where we delegate our cognition in very important respects. So when Dr. Lewandowsky said, "Oh, I don't know much about vaccines, so can the vaccine specialist, tell us about it?" That's a classic way in which normal human beings behave. We delegate our cognition in important matters to people that we think know better. But often we don't delegate them to people per se, we delegate them to tribes. And often it's a matter of whether or not you belong to a particular cognitive tribe. And in search of that cognitive tribe, you're often willing to trade off certain duties and, certain privileges for certain comforts. So by being part of a particular cognitive tribe, you're not expected to go through the end-to-end validation of a particular position you hold, especially that position that you hold is important. Of that tribe sets your cognitive boundaries, and you are fine to live in there. Just as if you lived in a real tribe, you don't question every taboo, you don't question every value system that the tribe holds. You kind of let some things go. So if you believe in you join a cognitive tribe, let's say you are a radical environmentalist, and there is increasing concern of not even, let's say you're a radical, you're in a particular progressive cause, you align to a particular progressive cause, and if you are a member of a particular progressive unit, a particular tribe, and one of the cardinal values of that tribe, or one of those labels that those tribes wear with pride, is a distrust of the pharmaceutical industry, then it does not make sense to dig too deeply beneath that label and ask whether the vaccine is right or not. I mean, it's being made by the pharmaceutical industry, they're evil, it must be bad. So in order to show loyalty to your cognitive tribe, you really don't spend time entertaining your doubts about the position they hold too much, because that would be disloyalty. So tribal cognition is very powerful in getting people, making people highly resistant to facts, or what we might want to call the truth. The last one is, and I think I mentioned this in the previous webinar, this idea of false holism. So we obviously know that we navigate between elements of holism and reductionism. We must simplify things in order to deal with them. But at the same time, every now and then we must strive for the whole picture. And that leads to a fascinating conflict in our minds, because in striving for the whole picture, we come up against limitations to our own capacity to absorb the whole picture. And that therefore then means that we go for the simplest way we can get to the whole picture. And very often, people that are conspiracy theorists or peddlers of misinformation are very effective in offering holism that is easy to assimilate. And unfortunately, that holism is often problematic. So how do you connect the fact that, vaccines, a lot of the companies that make vaccines have a history with veterinary services in the United Kingdom, and there's a link to imperialism somehow. It's very difficult to have the competencies that you require to build a truly holistic picture. If you yearn for holism, like most of us every now and then yearn for holism, you can go for a cheap holism, a holism in a cheap tuxedo. So that cheap holism is somebody telling you, oh, they're all connected, and here is how they're all connected on a silver platter. And very often, these types of false holisms embody numerous deceptions and numerous elements or pieces of disinformation. So that is one major reason why we have these situations as every now and then they emerge. I'm not going to go to a very few models that might be relevant as we drive forward towards the solution part of things. Cobble Mills is very popular. This idea that we have to also think in terms of who is doing the disinformation and who is countering the disinformation. So it's not a passive, active dynamic alone. It's often an active dynamic. People are trying to get to the truth. People are trying not to stop them from getting the truth, because getting to a particular type of truth, often a mainstream truth, is inimical to their broader or their strategic interest. So if I don't want you to get to a particular type of truth, what do I do to counter that? And often there are mechanisms around interpretation, mechanisms around degradation and perception that people engage in. So you think of propagandists, or you think of someone that has a reason not to like the vaccine industry for other reasons. It could be anything. It could be that there are historical crimes that the medical industry has committed that they can get over with. And how the person then actively sets about to counter the images that are and the messages that are being put through is a game theoretic model. So I'm not going to go too much into that. The other critical one that I think is important for us to keep in mind is this idea of non-overlapping magisteria. So this idea that there are domains of knowledge, and then there are domains of values or domains of other types of principles, and they don't connect. They are mutually exclusive areas, and then there are areas where there is some area of overlap. That has often led to situations where it becomes impossible to have a conversation about facts, because they argue that moral principles or other value systems and the rest of it are not factual things. They are beyond facts. Because they are beyond facts, we just can't have a conversation about them. So if I think that God made humans in a way in which we fight disease in a particular way, and vaccine science contradicts that, it's very difficult for me to accept that there is a conversation to be had, because my assumption is the domain in which I'm discussing these matters, maybe domains of values, domains of morality, domains of what we must do, does not interact or intersect with science. End of story. So how do we kind of try and address some of these things? First of all, we have to understand that it's persuasion, regardless of how we put it. We call it inoculation and all of these things. But fundamentally, we try to convince people about a particular mainstream truth. And that mainstream truth or that scientific fact must be persuasive. Now, the traditional way of looking at persuasion has been this very famous model of ethos, pathos, and logos. So the argument is that every element of persuasion, every time you're putting out some message, you have to have an element of ethos, which is authority. Why are you the right person to come give that information? So very often the argument would be, okay, let's get scientists to talk about it. And I think we've seen a lot of that in COVID. Let's put the scientists in front, not the politicians in front. There is pathos, which is that you need to incorporate some imagination and emotion and sympathy, and you cannot do it only ethos. And that's obviously logos, which is the scientific fact. The standard theory is that science is big on logos and very weak on pathos, and that it's sometimes good on ethos, but it underestimates the competition with other types of ethos holders. So if a religious leader is involved, do they have more ethos than scientists? In some communities, yes. In some communities, no. So in constructing the information, the traditional framework has been to take care of these three in the message. There must be logos, there must be pathos, there must be ethos. But truthfully, there are two other dimensions that are often missing, and that is that the context matters. This notion of agora and CCG is that all of them have to come together. The problem with bringing all of them together is that you come up against material limitations and constraints. How do you actually bring such complexity together? There has to be some emotion, there has to be some fact. And that is where my world comes in, the world of computing. So there is a new discipline in computing. It's not a new discipline, but it's getting a lot of attention now. And for that reason, it's becoming a very well-established part of the landscape called cartology. So the world of cartology is how computing makes persuasion more effective. And in that mechanism, we have a range of adaptive algorithms that are very effective in reading the situation, reading the context, having information on the background, having information on how to combine the elements. A lot of the missing piece of how to prepare information that is truly persuasive is often the context is not easy to access at the moment when you have to generate the information. And computers make that possible. So computers, for instance, gives you audience analysis. Computers makes it possible for you to understand what you are competing against, the information that you're competing against. They let you understand if a new development emerges. So those are all the Agora elements. So I talked about ethos, logos, plateaus, and I said, typically the traditional framework is missing Agora and CCG. So Agora, which is the context, is heavily provided by, or rather is really the domain of computing. Computing is extremely powerful in providing context on demand. So the issue is context on demand. And CCG is how you blend them. And computing is getting even more and more effective in blending emotion with fact with authority, by enabling you to understand why a particular element is more authoritative or not through rating systems. So one of the things we use in Twitter is the blue tick. You see the blue tick, it immediately tells you the person has ethos. You see the content in the form of short messages. So it has that element of fact, but you can also add video, which then brings in emotion, and it blends all of them together through the newsfeed model. So you go to a Facebook and they give you the newsfeed. What they're doing really is combining all of these elements into a very synthesizable stream. And that is the power of computing and the whole field of cartology. That also then includes the audience measurement, the ability to really measure the audience and figure out whether or not the message is working on the audience. Lastly, and before I get to my actual solution, there is a world of signature mining. So what I mean by that, when you take antiviruses, in the past, the way we understood antiviruses was you had an algorithm that could detect that something was a virus, and then you fought it because the algorithm was super smart. That has all changed. Now, the way we build antiviruses to fight viruses in the computing world, so now is to look for signatures and to keep these signatures in databases. So when I see a virus, I go to a database and say, hey, has anybody seen anything that behaves like this? And the great computing world looks through their different databases and say, oh yeah, actually this is a virus that was developed in Russia, and this is how it affects your computer, and here's how it's really hard to fight, but so and so has these solutions and it's working. So that's how we fight virus today. Now, the point is that we have to start becoming effective in identifying strains of misinformation. So Dr. Stephan pointed out that we know the kinds of misinformation that is going to come out around the COVID-19 vaccine. We must call that a strain. Now, there will be different types of those strains, and there have to be effective ways in building databases that record these strains of misinformation and figure out what other people are doing that is being effective through audience measurement. And that brings us to the more central theme of my talk, this idea that we cannot use one-way information mechanisms to address misinformation. We can't just produce great videos and just throw them out there. It doesn't make any sense. It needs to be engaged, organic kind of interactions. So if you're thinking of the online environment, for instance, where you want to find misinformation is in forums, places where people are engaged. So they're actually interacting with each other, they're producing information is coming back. And in that mechanism, you have the mining tools that enable you to do the audience measurement, the sentiment analysis as it's going on, picking up the information and testing the information as it goes into the forum to understand what information is working. And through those mechanisms, you find out what are the new elements of misinformation that are popping up in the forums, populating them, and then finding out whether or not you can create solutions that are distributed. So let me repeat that. We have a problem with understanding how to persuade people because we've traditionally relied on authority, fact, and emotion. And we've struggled to blend them effectively. More important than that, we often don't have context, so we don't know who we're talking to. New tools enable us to understand the audience better in real time, produce context on demand, and combine the elements of fact and emotion more effectively, deliver them into the forum, and then pick up the information back. And through that, we synthesize better, more persuasive messaging, redistribute it, recycle, redistribute it, learn the loop, and produce more effective communications that are indeed persuasive and can inoculate people against misinformation. Thank you.
Presentation. I think I'm going to open it up for questions. So I'm on the lookout for raised hands. Please raise your hand if you have a question. Nicole Grabble, go ahead and ask your question. And then we'll have Atta as after Nicole. Nicole, kindly go ahead and ask your question.
Hi, can you hear me okay?
Yes.
So my question is around the process that was just described, that, you know, we do have these new tools that can evaluate and synthesize information. My question is, in real time, when we're responding so quickly to information that's coming out, the process of doing that, mobilizing teams, getting that accurate information out, translated, distributed down to social, you know, community mobilizers and people that are doing engagement either through these sort of closed forums or closed networks. You know, what is a realistic expectation for how to do this in a timely fashion? And, you know, what's the fastest that people have seen and how this can work? Yeah, just some guidance on expectations around that, or speed and how to do it effectively. I just think that there is a realistic delay in processing that information and creating content, translating it and distributing it out to folks who can then mobilize within these forums or networks.
Thank you very much, Nicole. So do I answer Lucy, or how do we go about the Q&A?
Yes, go ahead and answer as I look for other questions. Yes.
Thank you. So Nicole, the way it works is that we need to use a practical kind of scenario for this to make sense. So the practical scenario is, think about a call center that, you know, is set up to help a community address issues of, where do I go to take my vaccine? I have a problem. I took a vaccine, and now I took my son to take the vaccine, or my daughter to take the vaccine, and now he has a headache, or she has a headache. What do I do? So there are always going to be these community focused information provision services. This is where one scenario in which we can be very practical. So the question is, if somebody calls asking you, hey, I just heard that, you know, the headache that my young child is facing is because of this vaccine thing, or somebody calls asking for help in some other way, or let's say you train a group of peer educators and then you send them out, what tools do you equip them with? So that is the context in which we're having this discussion, or at least one of the scenarios that we're dealing with here. So what I'm saying is that typically we don't think of this as an operational strategy. And we don't think, for instance, do we have a database that is helping us to identify what is the new strains of misinformation that is emerging? So we do our general coding for the transcripts, but we're not building these systems to design them around identifying strains of misinformation, as an example. So with this model, there has to be a database in which you are actively updating the signatures of deception that you are detecting. A second one is that when the person that is doing the responding has to quickly educate themselves, they need to find out, has this happened before? Have I heard this somewhere before? And that search functionality through the database to identify strains of misinformation helps if in the database also there are responses that worked. And that means, therefore, that when the person has finished, you know, being attended to, and you have a rating system, the rating system needs to link it to the response that was received to validate that response. So that in time, when you have another person calling or another person interacting with the service, asking questions, you know what type of responses were effective and which were not. So it's that operationalization mechanism that we are advising be considered, because that will then make it possible for the respondents to be equipped in real time with all the knowledge in the entire network as they engage, as opposed to learning, getting one training curriculum, going through that training curriculum, and then being sent out. And I think that model no longer works in the world of organic engagement. In the world of organic engagement, you need to be feeding them with the knowledge and the wisdom that is emerging from the network in real time. And that can be done through digital means. So they can have a tablet where they are able to pull up the latest information about that particular subject matter. They can, if they are in a call center, they can have a quickly searchable database. And these mechanisms are going to be increasingly powerful. When it comes to synthesizing information to generate, that will be harder. But there are tools that will enable people in a chat group who have been specifically planted in the chat group to pick up data that includes some emotive content, that includes some facts quickly, and put them in the forum as the conversation is ongoing. And some of those tools I'm happy to share with you later if you're interested. Thank you.
Thank you. Nicole, have you been answered well, or you have a follow-up question?
That's great. Thank you very much.
Okay. So we have a question from Edmund Kwak here. How do we fight vaccine misinformation in developing countries using the existing health promotion / education structures in ministries of health? So how do we fight vaccine misinformation in developing countries using the existing health promotion / education structures in ministries of health?
So Lucy, are you directing that to a specific panelist?
Yes, not really.
Well, these are my questions.
Yes.
These are all my questions. Oh, I understand, yes. Because you go on to the next panelist. Okay. So the way you do it, I think, is to do your audience segmentation very clearly. So when it comes to Ghana as an example, and I reckon you're from Ghana because of your name, you have Facebook as a very big platform for middle class professionals all the way to students and the like. And you have Instagram, which is almost for everybody else. And then Twitter for more or less the elite. Now, the question is whether or not the Ministry of Health has organic engagers, because a lot of the time they have these PR people who have canned messages and they want to deliver canned messages. Canned messages don't work, because the way that these things work is that the misinformation is like a genetic algorithm. It evolves. So think of it as an organism that is rapidly changing, and it gets better as it moves through the online forums. So talking about online alone, I think that if you are a Ministry of Health and you have a team that is designed to do community education, today you have to have an online team, and that online team has to be made up of organic engagers, people that are actually in conversation. This is where you then need these tools that I'm talking about to evolve the content that they can produce very rapidly and distribute. So if they're in a conversation, let's say there's a conversation around somebody claiming that that particular vaccine is laced with, let's say, heavy metals. Oh, we know these vaccines are laced with heavy metals. You need to be able to know some context immediately. Your engagers need to be able to know whether this has been happened before, maybe a few days ago, in some other forum, and whether or not there was some information that was delivered that was effective. If that is indeed the case, then I will agree that that information ought to be available to organic engagers on this social media platform. Then we talk about the people that are not online, which in Ghana may be 60% or so of the population. Peer educators that go around need to know what is the conversation happening on the ground there. And it's typically radio stations. So there has to be someone in the Ministry of Health listening to radio conversations, coding, because the way it works in Ghana specifically and most other African countries is that there's talk show programs in the afternoon where they have all of these so-called resource persons that are providing all this misinformation. You need to know who, you need to know what was it that they said, you need to know what is the counter that seems to have been effective, and it's through keeping that kind of database that you can assure your peer educators that are in the field providing their counter messages with real-time contextual information. So my argument is you cannot do this unless you are willing to engage in organic conversations in real time. Thank you.
Thank you so much, Bright. There's also additional response from Dr. Stephan. You can check in the Q&A. So we'll move on to the next presenter for now. The next presenter is Lucy Kanja, who's an EPI coordinator in Kibera and Lang'ata sub-county in Kenya. So she's going to share her presentation on practical experience and examples of managing misinformation to improve vaccine acceptance and immunization outcomes. Lucy Kanja, you're welcome. Proceed.
Yeah, good morning, good afternoon, good evening, depending on where you are connecting from. I'm going to talk about experiences and examples of managing misinformation to improve vaccine acceptance and immunization outcome. Next slide. In this photo, we have the team, and I'm going to share later about the photo of the baby that I'm holding. It is a success story as a practical experience. Next. Next slide, please. In Nairobi, we have different category of people. Nairobi is the capital city of Kenya, and we have the urban, we have the informal settlements, and also we have the residents. And therefore, when I'm sharing about these practicals, I'll be referring to all those people that are in the city. And here we have the teams that go to the villages and to our residents in case there is any misinformation. Next. Next slide, please. So this is the outline. No, this is the outline that I'm going to cover. Number one, we are going to see what are the biggest challenges related to vaccine misinformation that we face. How do we engage with the communities to address vaccine misinformation? What other stakeholders must come to the table? And what specific approaches have worked well to address misinformation in the communities in which I work? And what lessons have we learned that may be applied to future vaccine introduction? And finally, what has not worked well for us? Next. So number one, what are the biggest challenges that we face in relation to vaccine misinformation? All right, to say that any rumor or misinformation about vaccine can be a very serious threat to any vaccination program. And one of the challenges that we have been having is identifying warning signs, monitoring and reporting rumors and misinformation on time. Number two, having the presence of organized activists and religious groups opposed to vaccines and immunization who have the capacity to disseminate information has also been challenging, because by the time maybe the healthcare workers want to respond, the teams are already organized and they have heard there is a vaccine that is coming. They start planning early on how to oppose it even before the message is out there. And then number three, we have been having challenges on identifying a crisis communication strategy that can help to prevent rumors and outline appropriate responses after the rumor starts or even before the rumor comes on board. So those are some of the challenges that we've been having as far as vaccine misinformation is concerned. Next. Then how do we engage with communities to address vaccine misinformation? Number one, stakeholder engagement is very critical. And here we talk about all stakeholders that can be affected by the rumor. And we look at either the politicians, we look at the community elders, we look at everybody that is going to be affected, and we engage them as early as possible. And then we also do community dialogues. And in Kenya, we also call them barazas, where we call the communities that are affected by any rumor, and we sit and discuss about the way forward. And then after we have discussed with the community, we also do monitoring of community engagement, because sometimes we give them action plan and we want to know whether those actions have been followed up. And during that engagement, sometimes we call them dialogues. Sometimes we can have action days. We also do community messaging. And in some communities, we also have chalkboards where we record what we have been discussing. And sometimes we even do door-to-door visits, or we go outreaches so that we can get more people. Next. Next slide. So apart from the community, what other stakeholders that must come into the table? Number one, healthcare workers. Healthcare workers are critical when it comes to vaccine misinformation, because the community hold them with high regard, and if they become part of the spreading of the rumor of misinformation, it becomes even worse. Other people that we are supposed to put on the table are the parents and caregiver. Remember, these
Lucy? Lucy, are you there?
brought by on their behalf. And whether you hear me.
Your sound is cutting. Lucy, could you kindly turn off your video? Probably it's affecting the quality of the sound. Lucy, can you hear me? I think we've lost her, or probably. Unfortunately, we've lost her. So let me try and see whether we'll get her. Let's give her a few, like 2 minutes, to see whether she's going to connect back. And I think probably we can have this chance to take questions. So kindly raise your hand if you have a question, and I'll call out your name before we get Lucy back. Please use the raise hand button and you'll be unmuted. Please ask questions. So maybe in the meantime, I'll address one question to Bright. So in cognizance of tribal cognition and people who like selective exposure to information, as well as one of the challenges that has been mentioned. Okay, sorry, Shuk. Lucy, can you hear me?
Can you hear me now? Can you hear me? You can hear me? Okay, yes. Sorry, somebody called. I was tethering the phone. Okay. What the stakeholders must come to the table, I have discussed about healthcare workers, parents and caregivers, and also media, and policymakers and government leaders, because they come in handy when it comes to policy about misinformation, and also the gatekeeper to public opinion, such as community and religious leaders, immunization partners, because they come in handy when we want support, even to go to the communities. Also special groups. We have the spiritual healers, we have traditional healers, herbalists, traditional birth attendants, celebrity and religious leaders in some sect. In Kenya, we have sects that do not believe in even modern medicine. And so we need to engage them as part of the stakeholder, because they also command a huge following. And also mainstream spiritual leader. We have big churches which, if they give any information, it is taken and it may affect the vaccination program. Next slide. Next slide, please. What specific approaches that have worked well for us to address misinformation in the community I work in? Number one, it is defining the rumor. And by this, we mean we want to know, where does this rumor come from? Is it based on fact? Who is likely to be affected by it? We analyze that. How is it spread and by whom? When we answer these questions, they give us a new way of preparing a response. Number two, We also identify people and organized an organization responsible for fabricating that rumor. That way we are able to know how to talk to them and engage them. And if it is people that maybe are just giving out that misinformation because they don't know, those ones you educate them. But those that are deliberately spreading the rumors and misinformation, then we engage them. And when we are engaging them, we acknowledge the existence of that rumor, but now we go with factual messages. Number 3, we correct data and facts about vaccine immunization in preparation to respond, so that when we are going there, we have all the facts that have been given out. And then we target key opinion leaders in the affected communities, elders, and we sensitize them about immunization and seek their support. We make them like champions. We seek their support so that they can also talk to their communities. Then media engagement, radio, television, whether it is national or local FMs, we use all of them. Next. Next slide. Next slide. Yes, we also do advocacy through stakeholders forums. This can be done at national level, at county level, sub-county, up to the level of the community. We also deploy immunization ambassadors or champions. Like when we are doing polio campaign, we have polio survivors who go and speak about the disease and then how they have survived, and if their caregivers had taken them for polio vaccination, they could not be in the situation they are. We also have cervical cancer survivors. We use them as goodwill ambassadors. Then dissemination of IEC material, information, educational material, so that they give facts. Then deployment of health promotion officers. We have them from county level, local levels. We have them up to national level. Then we keep on reassuring communities that vaccines are tested, they are safe, and they are effective. Next. Next slide. Then what are some of the lessons that we have learned? Number 1, we have learned that engaging the church and other stakeholders at earliest opportunity give us an opportunity to counteract any information that may be out there that will affect the vaccination program. Number 2, exploiting all available channels of communication. If the information is on social media, we go there. If the information is on print media, there is a response for any channel of communication available, even if it means now using even the elders, community health volunteers, the community health assistants, health workers at the facility, every channel that is needed there, we exploit all of it. Then strengthening the local laboratory capacities, because you will see at a later slide that there was an issue that needed joint sampling of vaccine batches. And also we have learned collaboration of Pharmacy and Poisons Board, which is a drug regulatory authority for Kenya, has strengthened the immunization program with that collaboration. Then lesson learned is also accurate rumor identification and answering all concerns without looking at this is a small concern, this is a huge one, all of them, and also understanding community dynamics. As you have seen in my first slide, we have the informal settlement, we have the residents, middle class, we have the high ed, and you have to have the message to target all of them. And also in the process, you also build teams. Next. Next slide. So also, we have also learned lesson when we are doing one-on-one engagement with the caregivers, because we saw they are our part of our community. And number 1, we are saying be polite to the caregiver, friendly and caring. Even if you know maybe she did not come for the vaccination because of the rumor she had, then speak simply in a language that they will understand. Listen and understand their caregivers' misinformation questions and all the concern. Then give relevant answers to the concerns and questions, no matter how it sounds. You go to their level. Then respectively correct the inaccurate information. And finally, you give them, you thank them for the patience of even listening to you. And that has worked in our communities, especially when you are talking one-on-one to them. Next. Next slide. Next slide, please. Then what has not worked for us as well? Sometimes you may have top-bottom management approach. Sometimes it doesn't work because you may think at higher level that community A that has received this particular misinformation and they have been affected by it, you get a solution maybe that worked elsewhere and you come and implement it there. Sometimes it doesn't work and it has backfired. Then inadequate resource allocation, hindering implementation of planned activities. You may plan you are going to village A, you have all the strategies ready, the channels of communication, but the resources to make you move from point A to B, sometimes they are not there. So you find even a rumor spreading faster than now the response of the information. And most of the time, it even affects the coverage, it even affects whatever services we wanted to offer because the rumor is faster than us being able to act fast. Then competing activities. You may find the person expects to be in point A, resources expect to be in point B, and if there is no proper delegation, you may find there is delayed response. And also sometimes we don't have a lack of political goodwill. The politicians command a huge following, and so if they are not coming on board, sometimes we have issues. I have examples that I want to share of controversies that came and how we address them as a country. In 2001, Kenya started the journey for maternal neonatal elimination process, and we started the tetanus campaign. But it was all okay until 2014, when Aruma started from the Catholic Church, and they asked questions. Number one, they said that the TT that was being used for the campaign had beta human chorionic gonadotrophin hormone, so which could cause sterility and abortion in women. And they also asked, why is tetanus? Is there any tetanus crisis in Kenya? And if so, why is it not declared? And they also questioned why it was targeting the women of reproductive age 14 to 49. Next. So it was all over media, as you can see in this newspaper cutting. And the media was reporting churches defiant of tetanus vaccination. You can see on the other side, a Catholic bishop talking about that controversy in television. And so it was a huge, huge debate from the local village, from the local FM radios. It was translated to local community languages, and everybody was talking about tetanus vaccine. Next slide. Next slide, please. So what did the Ministry of Health do? They had a joint, as you are seeing in this newspaper cutting, they had a joint team to probe the tetanus jab safety, which included even the Catholic bishops, because as we have said before, any concern that is raised, you must also address it. So they formed a joint team, and they realized church had misinterpreted the test results, and also WHO, UNICEF came in handy, another ministry. And as the church went to media, also the Ministry of Health officials also went to media, trying to give the facts so that the community may know that the vaccine was safe to be used for our women. Next slide. Then we had introduction of HPV, human papillomavirus vaccine last year in 2019, targeting 10-year-old girls. Another controversy now rose. It was all over in the media. As you can see, these are online cuttings. We also had it in the television. Again, just like the tetanus luma, it also affected. And you see, the Ministry of Health also came to evaluate church claim. They did not just dismiss the claim. They also went and evaluated the claim, and they came together, and you'll see at a later slide, the Catholic now saying now they have agreed that the vaccine can be given to the 10-year-old girls. Next slide, please. So, and what do we do when we want to engage the refusing parents? Because some are given misinformation and they decide to stay at home. This is a scenario when we had polio campaigns, and the teams when they are in the field, they have missed children forms that they fill in. and they come and give to the supervisors, and they talk about the children that they have missed in the field. And now we go door to door to check on those children. And you can see we are engaging on one-on-one and getting the children. And once we engage them and they accept, we give the vaccine. Next slide. Here is a success story of that engagement. On my left, there is this baby, 4 months baby, who had refused, the mother had refused to give any vaccination. She has 3 other children who are vaccinated, but she had misinformation about vaccine and said the 4th child will not receive anything. And we talked to her. The baby was vaccinated with all vaccines that were due. And on the other side, we have 3 boys that 11 years, 8 years, 5 years, who the mother had said they cannot receive any vaccination. But after that, community health volunteers visited the house. They called the healthcare workers, and we had an immunization exercise in the neighborhood, and they agreed to come. Next slide, please. Next slide. Move to the next slide. Can you hear me?
Yes.
Can you hear me? Next
yes,
slide.
we can hear you.
Next slide, please. Whoever is driving the slide. Next slide. Let them move to the next slide.
Yes. Which slide is it? There's a lag.
This one.
Okay.
Yeah, that one.
Okay.
No, the previous one. The previous one.
Yes, there's a lag, but I'm changing them.
The previous.
Yep, no problem.
Yes. There was the previous. Okay, that one. We have also done high advocacy and communication and social mobilization. This has happened. On my left, there is the HPV vaccine. You can see there is media engagement, cabinet minister for health, a cervical cancer survivor, also engaging. And on the other side, you can see us in the community trying to talk to communities and calling them for immunization, engaging them one-on-one, and talking about any misinformation they may have had about immunization. Next slide. Next. You see also high-level advocacy of HPV vaccination. You can see in the first tweet, the president and the Catholic bishops, they were together launching the vaccine, human papillomavirus vaccine in Mombasa. The bishop for Mombasa was accompanying the president of Kenya. And in the middle, you can see me giving the human papillomavirus vaccine to a 10-year-old girl in an Activity Beyond Zero campaign. Here we are with the first lady of Kenya, of the Republic of Kenya. By then, the secretary for health. And we also had Nairobi Metropolitan Services Health Team with the first lady accompanying as part of high advocacy to vaccination. Next slide, please. Move to the next slide. Yeah, we also have the community outreaches where we go. And right now with COVID, we realize that people are not coming to us because they thought there is COVID infection in the health facilities. And so we planned activities to go to the communities. And we went even with, before and after the services, we were also fumigating the premises so that they are protected. And therefore, we have also been able to clarify any rumor about misinformation about vaccination during COVID, and talking to parents, telling them that vaccination is an essential services. So even when you are told to stay home, just know the child who is due for vaccination should be brought back to the facility, because there was that misinformation. They were told to stay home, then they stayed with their children. Next slide. and also empowering healthcare workers, because we want them also, when they are going out to the community, they are empowered and they know how to clarify all the rumors and misinformation, because they are our frontline soldiers as far as any rumor and misinformation related to health is concerned. Next slide. Next slide, please. Next. Yeah, and here you can see a success story of the girls that came for human papillomavirus. Their parents gave them permission for vaccination, and you can see us jumping the waters, going to reach every child in our communities. Thank you very, very much. Over.
Thank you so much, Lucy Kanja, for that presentation. In the interest of time, I'm going to invite our panelists for any final comments. So we'll start with Dr. Stephen. Any final words or comments?
Yeah, no,
Dr.
that's
Stephen?
fine. The unmute button was obscured. Sorry. Well, I thought these were very interesting presentations and everything. The only thing I want to reiterate, I mean, I'm not an expert in Africa or you know, communication in developing countries, but I do find I've come across a number of seemingly relevant precedents of crowdsourced debunking in Africa that was pioneered there. I put a link to a blog post I wrote about it in the chat. And so, you know, I think maybe you do have some precedents, some very amazing precedents to follow there. And if that happens, then I'd love to hear more about it. And I think the last presentation was going in exactly that direction. So thank you. And now I'll have to leave in 4 minutes. So if I disappear, let me say goodbye now. I have another meeting.
Okay, thank you. Angus, go ahead.
Thanks, Lucy. Thanks to all the speakers. That was absolutely fantastic. I agree with Steve. I think, I mean, Lucy Kanja's presentation shows that, in fact, there's probably more to learn from what's going on in countries in Africa for other countries around the world than in the other direction. This was really a fantastic presentation on how at the country level we should be managing misinformation. I want to reiterate, mentioned in the previous webinars, but UNICEF has developed a vaccine misinformation management guide. It's drawn on much of the work of Steve and colleagues, and it tries to operational.
I think we've lost you. Angus, if you can hear me.
I think a lot of what you heard from Lucy Kanja. Sorry, you can't hear me? Hello?
We can hear you now. Yes.
Okay.
Go ahead.
Where did I drop off?
A few seconds. For a few
so
seconds.
that misinformation guide, vaccine misinformation management guide, will be available in the next couple of weeks, and we hope that it will operationalize today. The last thing I'd like to mention, I see that we've got Wesley, who's just done the WHO Infodemic Manager course. To Nicole's question, I think we have a lot of work to do, and UNICEF and partners have a vision for this to embed the skills that kind of sit at the nexus of the kinds of listening that we've heard about from the field, but also the kinds of analytics that we've heard about from Bright that can be done on data that we're picking up, and then the transformation of that into actionable insights for the people in the field, you know, doing the risk communication, community engagement, social mobilization, etc. I think that WHO training is very exciting. We've got over 200 people who've been trained, and you know, our vision is that in the next while, we will be able to start to set up those people in countries with the tools, the guidance, etc., that they would need to start to do this in a systematic way, a lot of which will be coordinating what's already going on, but hopefully bringing in new elements as well. Over.
Thank you. So we'll have Bright and then Lucy Kanja. Then we'll invite Sarah Kester. So Bright.
Thank you very much, Lucy. Yes, very illuminating discussion so far. I just wanted to point out one fact, which is that there is a species of misinformation that is often founded on facts, on serious facts. It's just the interpretation may be wrong, but the facts are important. And so when we think of this, we should look at this issue around vaccine safety seriously. If there are people that do genuinely, we know there's a small percentage of people who do genuinely have reactions that are adverse upon taking vaccinations or any medicine at all. We have to have the technological means to enable the collection of this type of data and a transparent way of addressing them. So if I go to a place and I get a vaccination, or my child gets a vaccination and it develops a rash, there has to be a way to report it quickly, and there has to be a transparent way of assuring people that these problems are being addressed. It's a very critical way of addressing potential misinformation that comes from facts. So the fact that somebody had a rash really happened. The fact that that rash is evidence that the vaccine is bad for everybody is obviously a false misinterpretation. But until we handle the base facts, we will not be as effective as we could be in addressing the misinformation that feeds off these facts. So I advise that adverse reaction monitoring should be heavily digitized in order to provide the means to address genuine concerns in communities about problems with vaccines that could potentially arise due to poor storage, due to allergies, and other things that we know for sure can every now and then, in a very minor set of circumstances, create problems. Thank you.
Thank you, Bright. So Lucy and then Sarah, feel free to jump in after Lucy Kanja.
Okay, just to add on about the advanced events following immunization, because as my colleague has stated, it can also generate misinformation. In Kenya, we have ways of reporting any IFIs from the community, and we say anything that is of concern to the caregiver, to the community, to the health worker should be reported. And we have even the forms that are even at the facility level, and they are filled in triplicate so that one copy is left at the facility, another one is cascaded up. And nationally, we have a team that also respond to do the investigation so that they can tell whether is it vaccine related, is it the component, was it coincidental? So all those things are taken into consideration, and then feedback is given either to the caregiver or to the community that thinks that something happened. And that one has really come in handy, especially when there is any side effect. Again, even during vaccination session, our healthcare workers are trained also to talk of maybe expected side effect that they may come, like with measles, rubella, we know the child can get rashes. So we tell them in advance so that if it comes, they know, but we also tell them anything abnormal, kindly go back to the nearest facility, or you go back to the facility that you are vaccinated, and then the information is cascaded. Thank you. Over.
Thank you. I'll now hand it over to Sarah Kester. Sarah?
Great. Thank you, Lucy. And on behalf of Sabin and Boost, I want to thank all of our panelists today for a great discussion. I saw lots of questions in the Q&A and in the chat. So thank you for our participants for being actively engaged throughout today's session. So just a few pieces to wrap up. I know we're at time, so thank you to those who have stuck with us. So I just wanted to share some more information about Sabin's Vaccine Acceptance and Demand Initiative. If you want any more information, you can feel free to email them at vaccineacceptance@sabin.org. But we have a number of other programs related to vaccine acceptance and demand, including our small grants program, the Vaccine Acceptance Research Network, or VARN, as well as Immunization Advocates, which has resources for both journalists as well as health workers. So please feel free to follow Sabin on all of our social media to learn more about these efforts. And then Liz, if you could go to the next slide. Just also wanted to share a few steps to continue today's conversation. So to continue to engage in these types of discussions, we invite you to join the Boost community, which is our community of immunization professionals, of which both Lucy Carey and Lucy Kanja are members. On Boost website, you can also learn about future events and webinars similar to this. And then we also do have a brief survey that we invite you to take following this session so that we can get your feedback, improve on these types of engagements, but also understand what other resources or tools that you could benefit from related to vaccine misinformation. So with that, again, thank you all to our panelists, to the Boost, Sabin, and UNICEF teams for seeing this series through, and of course to all of our attendees today. Be on the lookout in the coming days for a recording of the presentation, the slides, as well as some supporting resources in your inboxes. So thank you all. Have a great rest of your day or evening, and we'll be in touch soon.
Thank you.